Welcome back to the Explainer Masterclass, everyone. I'm your lead instructor, and today we're diving right into Part 83. We are focusing on the incredibly high-stakes world of MDC-04, the respiratory system. You know, this is really where clinical complexity meets intense financial acuity, and mastering it, it's an absolute game-changer for your career. Now, before we jump into that clinical to compliance pipeline, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Herschel. Your support is what keeps this free educational journey going. All right, here's our quick roadmap for today's lesson. First, an intro and recap. Second, an overview of MDC-04. Third, we'll hit high-volume respiratory DRGs. Fourth, CDI and audit compliance. And finally, a quick summary and teaser for next time. Let's get into it. Section 1, Intro and Recap, where we are shifting gears over to pulmonology. So in Part 82, we explored the surgical depths of cardiology in MDC-05, right? Well, today we are pivoting completely. We're looking at MDC-04, which is just a massive critical medical driver of inpatient admissions and intensive care stays. Basically, we're shifting gears from the cardiac cath lab straight over to the pulmonology ward. Moving on to Section 2, Overview of MDC-04, Diseases and Disorders of the Respiratory System. Now, this diagram brilliantly illustrates the foundation of it all. The whole MSDRG architecture actually forces us to evaluate the principal diagnosis first. That's the condition established after study to be chiefly responsible for the admission. That single diagnosis completely dictates the major diagnostic category. Literally everything else flows from there. And within this category, you've really got to partition your thinking. On one side, you have your medical admissions. Think COPD exacerbations, status asthmaticus, pulmonary embolisms, or pneumonia. But then on the other side, we have cases requiring significant operating room procedures, like a tracheostomy or maybe a lung resection. The coding logic drastically shifts depending on which path that patient takes. So why does all this precision even matter? Well, let's look at the financial stakes for a second. If a coder misses a secondary COPD diagnosis in a seemingly simple pneumonia case, the reimbursement drops by exactly this much revenue, $2,300. Seriously, just one missed complication or comorbidity code, and you've lost thousands of dollars for care that the hospital actually provided. That brings us to Section 3, High-Volume Respiratory DRGs. Okay, when you're coding for respiratory support, it is absolutely crucial to distinguish between your root operations and ICD-10 PCS. Think about it. A continuous invasive mechanical ventilator moving air in and out of the lungs completely takes over that physiological function, right? So that maps to the root operation performance. Now, contrast that with non-invasive positive pressure like a CPAP or BiPAP machine. That provides constant pressure, but it merely assists the patient. So that goes to the root operation assistance. Getting this wrong, it will completely derail your DRG. And speaking of mechanical ventilation, 96 is your magic number. Mechanical ventilation for 96 consecutive hours or more triggers a massive global override for reimbursement. It literally pulls the case into a pre-MDC MSDRG tier, specifically 003 or 004, which carry incredibly high relative weights. Because of this, you must track those intubation and extubation times with absolute surgical precision. Also, acute respiratory failure isn't just one big bucket code. We really have to look closely and ask, is it acute respiratory failure with hypoxia, meaning critically low oxygen, mapped to J96.01, or is the patient retaining high carbon dioxide, which is hypercapnia, mapped to J96.02? You have to couple these very specific codes with those exact ventilation hours we just talked about to lock in the correct DRG tier, like 207 or 208. Let's see how this logic builds when we evaluate pneumonia. Missing the clinical indicators for aspiration pneumonia, like say a patient presenting with dysphagia, vomiting, or severe GERD, and erroneously downgrading them to a simple community-acquired pneumonia, is a super common and frankly a very costly mistake. Aspiration carries a much higher severity level, and your documentation absolutely must reflect that reality. So, what happens when these respiratory infections escalate? Well, when pneumonia or another infection cascades into sepsis, you must rigidly follow this specific sequencing logic. Step 1, identify and code the systemic infection. Step 2, code the severe sepsis or septic shock. And Step 3, code the resulting organ dysfunction, which in this case is acute respiratory failure. Rigorously following these steps is what secures the correct, compliant MSDRG triplet.
All right, Section 4, High-Yield CDI, Clinical Validation, and Audit Compliance.
Here's the deal. Payers and auditors love to target and downgrade acute respiratory failure to simple hypoxia. To stop them in their tracks, your clinical validation has to rigidly anchor to arterial blood gas parameters. You want to ensure the chart clearly documents a PO2 less than 60 millimeters of mercury, a PCO2 greater than 50, a pH less than 7.35, along with severe work of breathing, tachypnea, or a requirement for continuous high-flow oxygen.
And capturing secondary drivers. That is the absolute key to pushing a case into the highest relative weight tier. We're talking about aggressively identifying secondary CC and MCC conditions. Things like severe sepsis, acute corpulmonale resulting from a saddle pulmonary embolus, severe protein-calorie malnutrition alongside COPD, and acute kidney injury. These MCCs appropriately reflect the true cost of care for these highly complex patients. Which naturally brings us to CDI. Clinical documentation improvement is basically the defensive shield that validates every single code you abstract from the chart. It's the bridge between what the physician actually treated on the floor and what the coder can legally report. Honestly, without robust CDI, your revenue is completely exposed to audit denials.
Now look at how perfectly constructed this provider query strategy is. This is a compliant, non-leading physician query. It presents the clinical evidence, like an elevated lactate of 4.0, and it gives the provider all reasonable clinical options for the patient's status. It even includes an other and a no change option, so we aren't forcing their hand. This clarifies the documentation perfectly without violating any compliance guidelines. Finally, Section 5, Summary and Teaser.
I want you to keep these core takeaways at the absolute front of your mind this week as you group MDC-04 cases. Validate your respiratory failure indicators against the clinical lab values. Strictly monitor those mechanical vent hours to see if you cross that 96-hour threshold. And relentlessly capture those secondary CCs and MCCs to secure accurate reimbursement.
In our next explainer, Part 84, we're going to flip the script. We'll be tackling the incredibly complex surgical partitions of MDC-04. We're going to unpack the coding logic for thoracic surgery, long resections, pleural procedures, and major thoracotomies. You definitely won't want to miss it. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Hershal. And as you review your charts today, I want you to ask yourself one vital question. Are your queries leading the physician, or are they truly leading to compliant reimbursement? Think about it. I'll see you in the next lesson.